Good morning, all. This is Lori Walmsley, Chairperson of the Arizona Board of Pharmacy. I'd like to call this meeting to order. To get started, this task force shall meet to establish the procedures and conditions relating to the release of information pursuant to Section 36-2604. In addition, the task force shall identify educational outreach and support services to advance medical practitioners' adoption of the electronic prescribing of Schedule II controlled substances and pharmacy information. Finally, this task force meeting shall allow for collaborative discussion to continuously improve the administering of the controlled substance prescription monitoring program. The task force shall be composed of licensed healthcare professionals, licensing board, the Arizona Department of Health Services, professional associations, the Arizona Healthcare Cost Containment System, federal and state law enforcement agency, and criminal prosecutors. Welcome, everyone. Happy to have you today. This is August 26th at 8:30 a.m. We'll go ahead and start by taking a roll call. Dr. Gandhi, how would you like to do this? Do you want to call the individuals present, or would you like me to?
I can take care of it, Madam Chair.
Thank you.
Ms. Walmsley,
Present.
Ms. Kurt, Jacqueline Kurt, Ms. Susie Berman.
Here.
Mr. Williams, Matthew Williams, Travis Smith, I see him, he's on mute, I think.
Yeah, I can see Travis there too, Cam.
All right, I'll keep him on standby until I hear from him. Debbie Johnson,
Present.
John Morris. John Morris. Janet Weigel. Do not see her. I think she's just joining now. Stephen Borowski.
I thought I saw him just a few minutes ago.
He's there.
You hear it now?
Yep, I got you, Stephen.
Okay.
Thank you. Kelly Fine,
Here.
Michelle Ulmer,
Here.
Dr. William Thompson.
Dr. Thompson said he could not make this meeting, Cam.
Melissa Cotres,
Here.
Julie Antilla,
Here.
Aaron Croft,
Here.
Ryan Edmondson. I think we got an email from Ryan yesterday. He's not going to be in attendance.
Here, I'm here.
You are, sorry, Ryan, thank you. David Jerminski. Pat McSorley. Pat. Gail Anthony. Janine Don.
I'm here.
Thank you, Janine. Margaret Whelan. Justin Bohal. Boaz Alvarado. Travis Smith, can you hear me? Travis Smith. I see him, but I don't see his mic. Sounds like his mic maybe not working. I'll keep tabs on Mr. Smith. I do see him dialed in, but Madam Chair, we have 10 absent. Doug, how many people do we have on the committee?
Cam, it looks like there might have been a couple people that have since signed on. It looks like Jacqueline Kurth may have joined since you started. I don't know if there's anybody else that came in after you started the role.
Jacqueline Kirk, can you just
Yes.
acknowledge? All right, perfect.
Good morning. I'm here for Sheila.
And Janet Weigel is here for Josephine Zamudo.
All right. 2, 3, 4, 5, 6. So we still have 9 absent.
It looks like Miss McSorley also joined.
Pat, can you acknowledge? Pat McSorley.
Thank you. Yes, I'm here.
All right, thank you. We're down to 8 right now. I believe we have a quorum. Is that correct, Doug?
It would appear so, yes.
Madam Chair, it's all yours. I'll keep an eye out for the other folks as well and call them in attendance as I see them.
Thank you, Dr. Gandhi. Again, welcome everyone. This is Lori Walmsley, chairperson of the Arizona State Board of Pharmacy. Appreciate everybody's attendance today. And as I stated in the opening mission and purpose of our meeting today, I'm really looking for some open collaboration on these topics today. There's some pretty significant things that we're hoping to get through. So just again, thank you all for your participation and for being here today. Dr. Scavarla, do you want to go ahead and get started with item number 3 on the agenda? Or the reminder about the electronic prescribing requirement has been reinstated.
Thank you, Chairwoman Walmsley. I guess I'd first like to kick off by saying thank you guys for coming. I think anytime we get a chance to bring all these different people together from licensing boards, from associations, it's rare that we're all able to work together at one time. And I thank you guys for coming. Second, just the overall outline of the agenda. The beginning piece of the agenda is focused on what's happened over the last year since our last meeting. The second piece of the agenda really focuses on where are we going, what do we have on the horizon, what type projects are we working on, and maybe what future legislation changes would we possibly need. So I wanted you to just kind of know where I was going from the outline standpoint. And as Chairwoman Walmsley said, the first piece is just a reminder. Item number 3 is EPCS is back in effect. We went mandatory use of EPCS for C2 opioids at the beginning of 2020. During the state of emergency with COVID, that was lifted and it went back into effect in July of 2021. So all C2 opioids need to be sent in to the pharmacy by way of EPCS. There is an exception, and the exception is the veterinarian prescriptions. Veterinarian prescriptions can still be handwritten for C2 opioid C2 opioids. So I thought that what I would do is after I cover each item, I'd open up for any discussion, questions, and then we can move along to the next item on the agenda. So any questions for me about the mandatory EPCS? Okay. So then,
Hey, Doug, sorry. Sorry, I couldn't find the mute button fast enough. Is there anything that you think is needed in terms of outreach to providers about it? Have you guys gotten any calls or concerns about it? Or do you think it's going to be kind of business as usual? As you know, we're always willing to support that, but I haven't heard anything specifically. So I was just interested if you guys have heard any concerns about the reinstatement.
Well, thanks for asking, Melissa. For those that don't know, Melissa's with Health Current, and Health Current worked hand in hand with the Board of Pharmacy for the year and a half leading up to the mandatory use of EPCS. And one of my teammates, Lynn Curtis, who does outreach and education, worked hand in hand with Melissa and her team to collaborate and get the word out about mandatory EPCS. Back to your question, Melissa. No, we really, the first couple of days, of course, we had a few pharmacies saying, pharmacists asking, is it back in effect? And maybe the prescriber didn't realize it. What I noticed is, and I didn't really think about it, prescribers move to Arizona every day. And if you moved here during the time where that was the mandatory EPCS was lifted, it comes as a shock when July came. And we did have a few prescribers reaching out saying, what can I do? But we guided them on, how to reach out to vendors and get the EPCS software. Tramadol and Tylenol with codeine are non-Schedule II opioids. Those are drugs that may be able to be substituted until you can get set up with a vendor. And that was our guidance. But I think we've had very minimal questions about it since week number 1.
Great, thank you.
You bet. Well, if everybody's okay with it, I'm going to move on to agenda item number 4. And this really hones in on our work over the last year, and really highlights some of the wins we have, as well as our collaborations within the state too. So the first one that I wanted to bring up, and we talked about this during our task force meeting last year, was we were looking to put a MME alert, morphine milligram equivalent alert, in the CSPMP software. And last year we were talking about, well, what should be our threshold? And we arrived at the threshold being 90 MMEs as an alert. And we made it 90 MMEs because that's what our law says, is that if you're over 90 MMEs, only a pain doctor can write, or a prescriber that has consulted a pain doctor. So 90 MME seems like the right amount. CDC throws that figure around quite often. And what our alert does is medical practitioners will receive the alert by way of email, as well as when they log into the CSPMP system, they have a dashboard, and they can see the alert saying you have a patient that is over 90 MMEs. It doesn't shout out which patient right away, especially when you think about an email alert. You don't want that type of HIPAA information in an email. So the email just says, log in and you can see any patient that the alert is saying is over 90 MMEs. So, a question that we get a lot is about buprenorphine. And there was a point in time where buprenorphine had a incredibly large MME value, and it would take prescribers that wrote for buprenorphine up above 90 MMEs very quickly. About 2 to 3 years ago, the CDC eliminated an MME value for buprenorphine products. So what that really means is buprenorphine will not drive your number up over 90 MMEs. Buprenorphine has a 0 MME value. And again, morphine milligram equivalents. So we had already had a couple alerts out there that we had talked about in previous years. Those other alerts was, again, patients that have seen 5 doctors and 5 pharmacies within the previous 90 days. And then patients that were on an opioid and a benzodiazepine at the same time. So that together, it means we have 3 alerts that go out, and those are viewable from the prescriber's dashboard, and we send them to their emails. So I'll pause there and ask if you guys have any questions about the MME alert or any of the other alerts we have.
Doug, this is Janine Don. You said a couple times that only physicians can write for more than 90. Stuck on the word physician, is it or pain management specialists as an NP?
Janine, I apologize. You are correct. I'm using the word physician without taking into consideration we got nurse practitioners, PAs.
Okay. Just checking.
So I should be choosing a different word than I did. So I
Thank you.
appreciate you bringing that up. It would be all those practitioners that can write for prescriptions.
Okay, thank you.
You bet.
Doug, this is Dr. Borowski. Is there any special definition of a pain management specialist? Because everybody these days seems to be claiming that title without any experience, education, or certification.
Yeah, I think you have a great question there. The Board of Pharmacy has no definition for a pain specialist. So I can maybe pass that question on to the other licensing boards to see if they have one. I do not know of one.
Just for the record, the only ABMS, American Board of Medical Specialties designation for pain medicine is with fellowship after anesthesiology residency, PM&R or neurology, and a fellowship. At that point, there are only there are a number of other so-called boards that don't fit with the ABMS. But as I'm seeing in all the reviews that I'm doing, both with physicians and nurses, that most of the abuse is with these uncertified practitioners.
Hi, this is Susie Berman, and I just have a question on the alerts. Have you given any consideration for an alert for a patient who is on MAT therapy and also getting an opioid?
Susie, the first question was the patient's on an MAT medicine as well as a opioid. Is that correct?
Well, they're on an MAT medicine, and then for whatever reason, they get prescribed an opioid.
We have not. The alerts we have were built by our vendor, and I think what's important for us to know is like our vendor, when they create alerts, they become available for anybody and everybody to use. And when I say create alert, it usually is being driven by a certain state. A certain state wants a certain product. And once it's produced and made, then it becomes available for all states. The first state that wants that made, they shoulder the bill for that technology and the building of the product. So if our state feels like that's something that we want to pursue, the next step would be I would be reaching out to our vendor to say, can this be built? And if it can be built, how much does it cost? And do we have it in our budget?
Well, they may already be building it because it's now a requirement from CMS.
They are. I can tell you they're really good at shouting out what they have available for us. They haven't brought it up, but I can ask. That.
And I know they meet with CMS on a regular basis.
They do. Yes, ma'am. Yes, ma'am.
Doug, this is Debbie Johnston. I have a question. I think it's for maybe you and Melissa both. Are you, the alerts that you are coming up with for the prescription drug monitoring platform, are those aligned with alerts that are coming out of Health Current as well? Because there are, Melissa, I know you built in some alerts, care coordination alerts with the HIE, and I just would want to make sure that the two systems are kind of in alignment, because as you know, prescriber toggle back and forth between the two.
I can say that, we both have different types of alerts, but it's going to be alerts on different data. We have a lot of restrictions on, we can really only make PDMP data viewable through our portal. We can't hold on to it. We can incorporate it into the clinical data repository. So I don't think there's a possibility that we would be alerting on the same thing. Now, there is the question of, I think there's always a question of what might be possible if we could combine different data elements. For instance, to Susie's question about MAT and prescribing opioids, we have a opioid treatment program registry at the request of the OTPs so that they can check before they provide they're doing intake on a new patient for MAT to make sure that that patient wasn't dosed at a different clinic within the last 24 hours. So we're working on some of their statutory requirements. So there might be opportunities for alignment in the future, but I'm not too concerned that today we've got overlapping alerts because of the restrictions on what we can or really can't do with the PDMP data. We can only make it viewable.
Thanks, Melissa. That's really helpful. I guess the question was really more about conflicting alerts, and it sounds like that's not going to be the case because you use different data, and you cannot, as you said, you can't save the monitoring program data.
It might be worthwhile as a follow-up, Doug, that we could look at the types of alerts that are provided via the PDMP. I think the restriction on PDMP data still stands, but that doesn't mean we don't get the same data via direct clinical sources from a hospital or provider. We could still get the same data. It's just not going to be available through the PDMP. So our alerts are going to be more specific to admissions, discharges, transfers. We certainly have some lab-based alerts. We have COVID-based alerts. We're working on immunization alerts. So we don't have any today that I'm aware of that are medication related, but I do think it might be worth it, Doug, that we could just compare the types of alerts that we have just to make sure there wouldn't be the chance as we continue to build out more and with different types of data in the future that there's not a conflict.
I think that sounds like a perfect plan, Melissa. We have and any other dialogue that we'd like to have around this? Okay. How about the question was asked about definition of a pain specialist. Does anybody out there have one?
If anyone would, it would be Dr. Borowski.
I was hesitant to add to that because it seems to be a self-proclaimed specialty these days. They're really, other than the board certification that I mentioned with the training that goes with it, there really isn't any other certification that I'm aware of. But everybody's finding their niche, whether physician or nurse practitioner are prescribing. It's unfortunate, but that's what I'm seeing in all my reviews.
This is Janine from the Board of Nursing. Since there isn't a definition anywhere on in the rules or the laws, if we have an incident, an investigation, we will ask them to provide the specialty training. And generally what we see is that they go through the pain management course, which I think is a 2-day course now. But that seems to be what's available anyway to the CSPMPs. And ironically, we haven't really had many issues related to that.
Well, this is Matt Williams with the AG's office. If we're referring back to the statute requiring limitation of 90 MME per day per prescription, it's listed under 3248.01 subsection C, which actually doesn't limit it just to board certified pain specialists. It says that if a health professional believes that a patient requires more than 90 morphine milligram equivalents per day, and the patient is not exempt from the limit pursuant to subsection B, which discusses other types of patients that are not limited in these ways to this limit, those in hospice care, those with oncology diagnosis, etc. The health professional shall first consult with a physician who is licensed pursuant to Chapter 13 or 17 of this title and who is board certified in pain, or an opioid assistance or referral call service, if available, that is designated by the Department of Health Services. And it gives more guidelines on how that can take place. So if we're just referring back to what is a violation of this statute, it lists more than just consultation with a board, someone that's board certified in pain. It also lists out an opioid assistance or referral call service if you reach out to an individual with one of those agencies or entities that's designated by the Department of Health Services.
Matt, thanks for sharing. Does anybody have any comments for Matt or anything that you want to keep talking about regarding?
If I may, this is Pat McSorley, and I recognize Dr. Boraski's concern. I think it's been one of those things that's been discussed because of the statute and the language of the statute. When somebody is practicing or prescribing for pain, I mean, when we review the cases, they're held. Everybody's held to the same standard. I understand the concern about the certification issue, but there are other people who do prescribe for pain.
Any other dialogue on this? All right. Are there any wants from the task force on that subject? Well, then I'm going to move along. Okay, guys. Item number 4B would be, I wanted to highlight a little bit of our collaboration with Maricopa County. So we were lucky enough to work with Maricopa County, and it's through the Overdose to Action Grant. And the Overdose to Action Grant is part of CDC funding that Arizona receives. And that CDC funding, it comes into the Department of Health as well as to Maricopa County also. And really what we have is the ability where we were able to hire an epidemiologist to help work in conjunction with Maricopa County. Like Melissa had said earlier, our data is really restricted on who can have it and why they can have it. So Maricopa County wanted to really match some data that they had regarding non-fatal overdoses with PMP data. And what's really neat is that through bringing this epidemiologist on board at my staff and working in conjunction with the epidemiologists at Maricopa County, we were able to marry up the pieces of data, in particular, looking at those non-fatal overdoses and what the PMP history was leading up to that overdose. So on page 4 of the packet I had sent to everyone, it highlights like how many patients that were in the study or in this particular, we're doing this monthly, by the way. So this is one segment of the population of those that had overdosed. And there was 159 patients that overdosed in this time period that I put into your packet. And out of the 159 that overdosed, 37 of them had controlled substances on their prescription drug monitoring program report over the last 3 months before their overdose. I'm sorry, 37 of them had a controlled substance. 20 of them had an opioid prescription. And then 11 of them had greater than 1 opioid prescription. Again, that was over the 3 months leading up to the overdose. So when you look at those numbers, I think, I don't know about everyone here, but I was a little bit shocked that some of those numbers were so low. And I'd love to hear your guys' thoughts too. But if 159 overdosed and only 20 of them had an opioid on their PMP report over the previous 3 months, and only 37 of them had any form of a controlled substance filled for them, it makes you stop and say, well, why are they overdosing? And I can't say for sure, but I think we all know that the illegal fentanyl is out there and it's on the streets, and a lot of people are getting their hands on the illegal fentanyl. So I can't say I know it's from fentanyl, but whenever I looked at those numbers, that's the first thing that came across my mind. I think what a couple other neat pieces of statistics was that when you look at that, those that were using a controlled substance or an opioid, only 25 to 30% had a controlled substance prescription, and only 10 to 14% of those had an opioid prescription leading up to that overdose. So I guess from my seat, I sit there and say, boy, do we, I know what I do from the PMP standpoint, but is there more need to talk about fentanyl? And I know we do talk about it. And, but if that many people are overdosing with that few amount with an opioid or controlled substance in the last 3 months, I guess that's where my brain went. And I'm going to quit talking now, and I'd rather hear what everyone else has to think.
Well, we've, as physicians, have primed the population by prescribing opioids based on the misinformation from the pharmaceutical companies about their safety. But it would be helpful because you're not finding the prescription in the PMP to associate with the overdose. If you go back in a 10-year query for the PMP, you might find that they were primed with opioids for years and then suddenly discontinued when the legal issues came about, and the docs shut them down and they went to the street. So this has become a problem. And I've noticed that the guidelines just ask for 1 year of PDP background. So on a first prescription, it really would behoove the prescriber to look up the full 10, 11-year history to see what's going on. It's not unusual that we see a patient who's been injured or has pain, and you ask whether they've ever had problems before and they deny it. Then you look at the PMP and you see years and years of opioids and benzos. So it really is important to look at that, take advantage of the full history in the PMP.
Doug, to that point, how long is the PMP information available? Is it available that far back for prescribers and pharmacists to look if they so choose?
It goes back 7 years, is what our statute says. We haven't eliminated some of the data out of the PMP that's older, but it is something that will happen in due time. You know, some of the old data, yet the questions around it had a lot of variables that I couldn't answer. But I think that Dr. Borowski is, you know, I've challenged the CDC with the same thing, Dr. Borowski, that if you've been driven to get your opioids on the street, you might get lucky for a month, a year, 5 years, but often sooner, at some point, you potentially are going to get a bad batch of fentanyl, and that sometimes is where you end up with that overdose. But I'd like to hear more from you.
Just regard to the time limit, I am finding data going back to 2011 on many of these PMP reviews. So
you are
years is what you essentially can get, but if you can ask for 10, 11, then you might be surprised to see it goes back that far.
Thank you.
This is Erin Croft with DEA. I think I can speak a little bit to some of what we're seeing on the street, since it's probably a little bit more what we're doing. And I was actually involved with an overdose task force in Tucson. So a lot of the deaths there are either fentanyl or methamphetamine. The fentanyl most of the time is the counterfeit M30s that we're seeing. We do see some mixed toxicity, which might go to some of our practitioners because they're legally getting a benzo and then buying fentanyl on the street, and we'll end up seeing the mixed toxicity on the overdose. But for sure, and I would agree with the doctor, if we went back a while, some of these probably at one time were taking legal oxy and then switch to the M30s, because I can buy that pill for $4 a pill on the street, which is much cheaper if I'm now an addict and can't afford it legally any longer.
Aaron, for those that may not know, what would you tell everyone what the illegal M30 is?
So the majority of those that we seize in DEA are going to be a fentanyl pill. Sometimes they're laced with other drugs, but for the most part, it's fentanyl and like acetaminophen or some other cutting agent. They're being manufactured in Mexico, or the fentanyl comes across and it's tableted over here, and it's meant to look like an oxycodone, the generic M30 that, for whatever reason, the addicts think that's the best one. So that's typically the one we see, but you will see other generic oxycodone 30 milligrams out there if they're able to get the punch dye to label them that way. Since we're so close to the border, most of our stuff comes across from Mexico, but throughout the US, there are actual labs on this side that are tabulating fentanyl to make them look like oxycodone.
Thanks for sharing.
Hey, Doug, this is Jackie. So at ADHS, we have the State Drug Overdose Fatality Review Program. And in looking through the 2020 3,000 fatal overdoses, approximately 50% of those involved illicit fentanyl. So it's clearly illicit fentanyl driving the fatal overdose numbers. And as Aaron mentioned, a lot of mixed toxicity and methamphetamine on board. So we're seeing a lot of polysubstance use, but really it's the illicit fentanyl that's driving the fatal overdoses.
Thanks for sharing those numbers from ADHS, Jackie.
If I can pop back in for a minute, Doug, just so everybody is aware, the methamphetamine is starting, the cartels have gotten smart and they're actually starting to tablet that to look like Adderall. So that may be a future problem we'll see, particularly with prescribers, if we start seeing more Adderall prescriptions because the cartels are now starting to tablet the meth to look like Adderall, which I honestly think may become a problem on like college campuses.
Yeah, Aaron, I hear a lot of that during the conferences that I attend to. And matter of fact, Jackie and I have talked about, from the standpoint of like, are we seeing an increase in stimulants in Arizona? And right now that answer is no. And it really caught us both by surprise. We thought we might see an increase in stimulant use. And Jackie, you may have some more comments that you'd like on that too, but throughout the country, the trend is increase in stimulant use. And I would imagine one day we're going to be meeting talking about stimulants too.
Yeah, so the CDC is funding our grant, the Overdose Data to Action Grant that we share with the Board of Pharmacy. We will be tracking psychostimulants. They've asked us to perform surveillance on psychostimulant use as well, beginning this next funding period, which is 9/1/2021. So, and we are seeing a lot of meth, not as much, percentage wise, it doesn't show up, but we do see it a lot in the fatal overdoses. And with chronic methamphetamine, as most of you know, there leads to cardiovascular disease. So oftentimes the ME offices are not having the cause of death methamphetamine. It could be contributory, but it leads to all kinds of comorbid conditions for these folks. And we see people in their late 50s and 60s using meth and in conjunction with other drugs. It's just a recipe for disaster.
Any other comments you guys would like to make regarding this part of what I wanted to talk about? And if not, what I wanted to do is share a little bit about, we talked about the first piece of what our EPI is doing, and that's like the collaboration month by month with Maricopa County and working with our epidemiologists too, and marrying those pieces of data. The second piece is she helped build a data dashboard that we have up on our CSPMP website. And page 5 of the book that I gave you guys, that has some interesting statistics, and it tells a little bit about what each of the dashboard items are measuring. So I thought I would have Lynn help me out here, and he's gonna just demonstrate the dashboard for you guys. And why I think it's really important that we got this up is, when I first came into role, there was so many questions, requests for data, and we really couldn't react to all those different requests in a very timely manner. We were a small group at that time, and I couldn't get to the answers in a very timely manner. So what this data dashboard does is it allows researchers and public health to be able to pull some numbers pretty quickly. Albeit it isn't an end all be all, and there'll always be data requests with the CSPMP, but putting this little bit of easy to use dashboard with some pretty cool pieces of data, we're proud of it. And Lynn, if you would demonstrate a little bit, if we look at the top left dashboard, this is the number of opioid prescriptions, and you can hover over each county and you can see how many prescriptions were filled there. Again, that's number of opioid prescriptions. So you might be saying, well, 15 million, that's a big number, and it sure is. But if you look at the bottom right, you'll also see that right now we have that at year 2016 to 2021. So you can use that slider there and you can, narrow it down to year by year if you were looking for data like that. And Lynn's demonstrating there right now he has from 2017 to 2019. And then if he hovers over Maricopa County again, you'll see that now we're down to 8 million from the 15 million. And that makes sense because we cut our timeline in more than half. The other area of this dashboard that you can filter is the counties themselves. And, up top, you can see right now they're all checked. And you can uncheck it and just click Maricopa County. And sure enough, you'll just get figures around Maricopa. And that becomes a little bit more important with some of the other the other charts here that I'll go over with you guys. I think when we talk about the second chart is instead of looking at the number of prescriptions, we're looking at the number of pills or tablets. And I think that's pretty self-explanatory. The next graph down is the age graph. And you can see, the highest age group from 2017 to 19 right now is what Lynn has it as. The highest age group for receiving opioid prescriptions is the 55 to 64. And then the second would be the 65 to 74 age group. But as you move over to the top right, what we're looking at there is the trend. We tried to put it into a where you have a line that you can follow, and the trend. Lynn, would you maybe change that back to 2016 to 2021? And you can see the line is a little bit more pronounced. There is a decrease in the number of prescriptions. As you can see, that it has a major drop off in 2021. That is not because of something miraculous. It's just all the data of 2021 isn't in there yet. We're still in the middle of the year. So don't read into that being like a major drop off between 20 and 21 right now. And then the bottom two is, we have an overlapping benzo and opioids by year. And we tried to think about how would we want to measure it, because some might want to know how many patients are on an opioid and a benzo at the same time. And, so that becomes the line that Lynn's hovering over right now. And then the one above is how many prescribers were part of putting a patient on an opioid and a benzo at the same time. So I think what's important to say there is that if one prescriber wrote the opioid and one wrote the benzo, they're both counting there, right? Because they did one or the other piece of that dangerous combination of medication. Some interesting facts is that between 2016 and 2020, there's a 32% decrease in the number of opioids. There's a 37% decrease in the number of benzodiazepines. There's actually 11% decrease in stimulants. So those numbers may or may not catch you off guard, but I thought I'd share those. And again, depending on the question you have, you can use this sliding scale for the date range. Pick your counties. Maybe you only want to look at a couple counties. Maybe you want to look at the whole state. It allows you to really hone in. So I'm going to just stop there. I don't want to talk about this dashboard forever, but I wanted it to be known that it's out there. And if you have questions, I'll do my best to answer.
Doug, this information is patient facing and practitioner facing, right? So everybody has access to look at that if they wanted.
That's exactly correct. So you would get to that dashboard through our CSPMP site, And if you went to our Board of Pharmacy site, from the Board of Pharmacy, click the CSPMP tab on the top right. Once that opens up, you click the data tab, and you can go to the data dashboard. Anybody can use this anytime. We update this monthly.
Thank you.
Any other questions or comments about the data dashboard? Last thing I'll say on is I really can't thank Maricopa County enough. They without them helping me fund an epidemiologist to do this, it wouldn't be up. And I think it does help public health a lot. So I'm going to move on then to, oh, go ahead.
So I just had a question on the Maricopa County data. You had data on, did you have mortality data?
Non-fatal overdose.
So you didn't look at those that actually, I'm just wondering what the numbers were for mortalities. So you didn't look at any of the mortalities.
That's not what was provided to us from Maricopa County.
That would be an important piece of information to know, not only the non-fatal, but what was the mortality rate?
Yeah, we started where we did, and we're looking to do that. That's already being discussed between the epidemiologists, and we're going to keep doing as much as we can of marrying a data and trying to do as much analytics around that. I have a feeling next year you might hear a little bit about that. I hope.
Is there someone from the DEA that sits on this committee?
It's not a committee, Pat. It's a grant.
No. I mean, on the committee that we are today, the CSPMP. This
sure. We have two people. We got Julie and we have Aaron on the call.
Okay, so we'd be interested to know how they are addressing what is happening from the DEA level, because we've been seeing the pendulum swing since the opioid crisis came to light, and all of the utilization management has been instituted. So we've been seeing the pendulum swing in terms of higher mortalities and more use of fentanyl. So it would be interesting to hear what the DEA has been doing as well.
So
and Aaron, I'll let you go, but in particular, Pat, what you're asking them what they're doing about what piece?
On the federal level, when it comes to illicit drugs, specifically all the fentanyl that's coming into the United States or being made in the United States.
So to speak on it a little bit, there's been different pushes in the last few years, and a lot of them are still in place. In particular, there is a lot of push to look at the illicit fentanyl that's coming across. We've definitely started looking at the manufacturer of the pills themselves. So where are the labs at? Where are they getting the equipment to do it? And trying to track those back and dismantle the labs. But we've also created task forces in different divisions based on what we're seeing with the overdoses that are specifically investigating those deaths. Because typically in the past, that was more of a state and local type thing, but now they're kind of teaming DEA in with those task forces. And there's actually a really good federal charge for trafficking resulting in serious bodily injury or death that is up to 20 years in prison. It's typically more than 10. So if we can get a trafficker on that particular charge, they'll be going in for a little while. The issues become what we had talked about before, which is mixed toxicity. If we have a mixed toxicity overdose, then it becomes a lot harder for us to prove in court. This particular drug dealer, who I know sold a fentanyl pill to me, but I also had benzo on board, the juries won't usually convict because they're going to say, well, 2 drugs were in there, so what really caused the death? So we do have the task forces out there that are trying to address the overdoses in particular and track them back to a particular drug trafficker. And then in standard, as DEA does, we are still working on the drugs coming across the border and coming into the US and trying to attack the overall organization as a whole. That's no different than what we've done for years with all drugs. It's just now they've turned it into what looks like a pill. And I think that goes back to the years of we had plenty of opioids getting prescribed, and now we have lots of people that are trying to find a cheaper way to continue to get their opioid.
Any follow-up questions for DEA, Pat?
And I guess one other thing I might say is I think we're all playing catch up. So everybody's kind of talked about it a little bit, but in the last 10 years, MEs have started to have to change their routine as well, because I think originally the toxicities just said opioid. Now they're being a little more specific and testing for different things, which also makes a difference for us moving forward on those kinds of cases as well, right? Because now we can say it was fentanyl versus just an opioid. So that data has been catching up now as well. And it varies across the country, but in Arizona, we are getting it actually broken down. And we've been getting the data, at least in Tucson, and I would assume Phoenix is getting the same thing. The MEs readily share with us like what their overdose deaths were. We can get a spreadsheet out of them to see for a certain time frame what they've actually had come through their office.
Jackie B, we're talking about fentanyl so much right now. There's a big push on fentanyl test strips too, right? Is that something you can speak with this group about?
Yeah, so the law, I can't remember which Senate bill it was, but it passed and was signed into law, and which allows for the use of fentanyl test strips. And with some of the grants that we have at ADHS, the CDC is providing us with funding to purchase fentanyl test strips. So we will provide harm reduction organizations with the fentanyl test strips and some of the law enforcement agencies to be able to use the fentanyl test strips. And just to kind of piggyback on what Aaron was talking about, we received the autopsies for all the fatal overdoses, and they are doing some toxicologic testing now, and so we do get levels for the different types of opioids. They break it out on, what the decedent has tested positive for, so what's in their system at the time of death.
Thank you.
Yeah.
Doug, this is Matt Williams again, the AG's office. Just to follow up on what Aaron was saying, is that there is a lot is being done at the federal and state law enforcement level to try to combat illicit fentanyl and illicit opioids, and also illicit drugs in general, since we've also seen an uptick in overdoses involving methamphetamine. As Aaron was saying, there are federal statutes, and also there's been a push by some state prosecutors to try to tackle this issue, especially in the areas of overdoses. The law makes it a bit difficult to prosecute in that area for a death. But here in the Attorney General's office, our drug unit, I believe last year, I saw the numbers correctly, is confiscated or interdicted 1.9 million illicit fentanyl pills, if I have that number correct. It's a lot is being done. Unfortunately, the flood or scourge of illicit fentanyl is something that we are all trying to respond to. However, these numbers that you shared with us today regarding the the dashboard, and the decline in opioids and benzodiazepines and stimulants is refreshing. And it's nice to see some good news, because I remember seeing a lot of these different, I think we all remember seeing these numbers at prior conferences and during the opioid epidemic, where we're seeing those small upticks in different groups. So seeing numbers coming down is promising. But law enforcement and regulatory agencies, we're all working in this together to try and ensure the health and safety of all the residents of our community.
I think that's well said, Matt. It doesn't matter which conference I'm at, and they all sound very similar. Where we're talking about the need to work together. We're talking about the fight on the illegal drugs coming in. The use of prescription monitoring programs, and it all ties together. Well, if you guys are okay with it, I'll move on and briefly hit on item 4C. And 4C is really page 6 and 7 of the book I gave you guys. And really, there isn't a meeting that goes by that we don't shout out our integration work. And our integration started with integrating with the HIE, which is Health Current. And then many entities wanted to integrate their own EHRs with the PMP, and we'll integrate with any of them. So that really becomes a business decision from the standpoint of the healthcare facility. And we've integrated with big hospitals. We've integrated with big chain pharmacies, and with one goal in mind: to make the PMP as easy to use as possible. And no one likes to have to log in and get logged out every 15 minutes. So when you're integrated, you don't have those issues. You don't have to remember your password, because it uses the credentials that you log into your own software system with. So right now, we have 71% of prescribers have the ability to use an integrated product. I want to be clear, I'm not saying that they all are using the integrated product. I'm saying they have the capabilities. So we want to one day get that to 100%. All our major chain pharmacies have integrated. So it's making it easy for not just the medical doctors, the nurse practitioners, the PAs, but also the pharmacists too. Like, let's make it as easy to use for anybody and everybody. I put in your book a little bit about like what our marketing approach is to try to let healthcare entities know that they have the ability to integrate. But if they use the HIE, they can log into the PMP through the HIE also. You don't have to integrate your own healthcare system. It's just an option that some have chosen to do. So I know I've talked about that every year, and I promise I'll talk about it again next year, because it's such a huge focus of the federal government. The federal government is focused on interoperability, and that's how we can do our part, is to make us the most interoperable PMP possible. So I didn't put it in the book, but when you think of interoperability, you also think about data sharing across state lines. And we do share data with, we're up to 41 states that we share data with, as well as the military health system has their own PMP. And when you think of military health systems, think about like all the different bases in the entire country, and they all get lumped into the military health system. Military health system is they basically become their own state PMP. It's just like one state. Instead of saying Arizona and Ohio and Pennsylvania, you would say all military bases become part of military health systems. And that's like another state that we connected with, if you will. And then this past fall, we integrated with the VA system, which was a huge win. You know, that for years there's been that blind spot where if a patient was treated at the VA, did the prescribers and the pharmacists out in the civilian world know like what? So maybe at your private practice or at a Walgreens or at a CVS, how do you know what's happening at the VA? So by integrating with the VA, we've been able to, allow a more holistic view of the patient's opioid use and controlled substance use. So I'll pause there, and if there's any questions, I'll answer, and otherwise I'll move along.
Doug, I just had a question regarding the integration campaign. How many emails were sent?
So each prescriber received a total of 3 or 4 emails over that month and a half that I shared with you guys in the on page 6 of your book. And those emails were sent over the course of about 6 weeks. And then
so 3 or 4 emails.
And
but
then
do we know how many actual prescribers were sent an email, I guess is my question.
Everybody that had a registration in the PMP. So that's about 23,000, 24,000. That changes.
Thank you.
Does that help? Yeah.
Thank
and
you.
And monthly, we put in an announcement in our AWARE system. AWARE is what the prescribers use and the pharmacists use to check the PMP. And once a month, we throw an announcement up there, just reminding them that it's a possibility. Any other questions? All right. Let's move to item 5. So newly passed legislation, which was Senate Bill 1091. This may have looked confusing to you guys in your book, and that's like page 8, 9, 10, 11. And if it looks confusing because it looks repetitive, I'm sorry. In some ways it is repetitive, but I think the important piece about Senate Bill 1091 is it gave access to the PMP for health insurers. And not just the health insurers, but contractors of health insurers too, in some cases. So when from the seat I sit in, I have to create roles within the PMP system to allow you to register as a healthcare, as an insurance role. We've always had roles for prescribers, roles for pharmacists, roles for law enforcement, roles for medical examiners, and the list goes on and on. But now we have a new bucket of people that have access to the PMP. So we had to create these roles. And what I wanted you guys to know is I made one role that is strictly for Medicaid and another role for all other health insurers. Right now, there is no difference in what one can access versus the other. But over time, I was trying to be forward thinking, and sometimes Medicaid will get the ability to do something before other entities. And I wanted us to bucket Medicaid into one role so that if any of that happens, I don't have to try to take people out of one bucket and put them into another bucket. So if you're looking at those pages are repetitive because really the creation of the role is the same either way. but we just made a name, one being Medicaid provider, Medicaid insurers, and the other one being all other insurers. Both of them can have delegates. The delegates have to be certain licensed delegates. And that's why you see that list of those on page 12. Page 12 gives the list of those that can be delegates for those in the insurance role. The insurance role still needs to be either like a supervisor of being a doctor, a prescriber or pharmacist, and then the delegates would be those listed on page 12. I hope I explained that well, and if not, it's probably easier just let you guys start asking questions rather than keep talking. But you know, ultimately, we got health insurers are now have the ability to use the PMP. There are prescribers and pharmacists that work for the insurers. They can have accounts and they can have delegates, and the list of delegates are on page 12. So I'll stop there, see if you have questions for me. Okay, I'm moving along.
Doug, maybe should we take a quick break before the next item? We've been going a little over an hour, just to give everybody maybe a 10-15 minute bio break.
I'm okay with that. Sound good to everyone? How about 10 minutes and then we'll come back.
Sounds good.
Thank you.
Yes. Back in. Come on. Locked. Okay, I'm gonna go back to my position.
Welcome back, everyone. Dr. Grande, do you want to take quick roll call or do you want to just jump in?
I think we jump in. I do see everybody from a roll call earlier. I did get an email from Matt Williams, who is dialed in listening, but having technical difficulties with his microphone.
Okay.
So he is present.
Okay, terrific. Doug, do you want to pick up with item number 6 on ongoing improvements?
Thank you. Absolutely. So ongoing improvements. First thing I wanted to touch on is the Arizona is upgrading our standards for reporting into the prescription monitoring program. So who's that affect? That affects the data submitters. For the most part, that's pharmacies. And Arizona's been used in version 4.2 for quite a few years. Since 4.2 came out, there was 4.2a and now 4.2b. So we are requiring data submitters to submit in the 4.2b format starting in November. We put out announcements. We've email communication, website, educating data submitters and pharmacies about the need to upgrade to that new format. ASAP standards is what every CSPMP uses. It stands for American Society for Automation in Pharmacy. Those standards have been around since PMPs have been around. And all the 4.2b does is adds the ability to add in a few pieces of information that 4.2 does not allow for. Those pieces of information allow the ability to collect ICD-10 codes, allows the collect a sold date on a prescription. And there's some other things too. I'm not going to go into all the details, but by upgrading, we are able to be reactive to any legislative changes. If I don't upgrade, then we would have to allow pharmacies and data submitters the time to upgrade if there was a legislative change, and that could cause problems down the road. So I just wanted you guys to know about that. If you have any questions, I'll answer them, but that's really all I have to say on ASAP standards. Okay, I'm gonna move on. You know that we're talking about ongoing improvements. Last year we started this discussion about the CSPMP and measuring compliance around the PMP. And when I think of measuring compliance, I think of a couple things. I think of measuring are people registered to use the PMP, and I think of, are they using the PMP? And then from a pharmacy side, are they reporting into the PMP? Because obviously, if the pharmacy doesn't report it into the PMP, you don't have good data as a practitioner to make the best healthcare decisions. So it starts there. But then once we have the data, are we using the data? Well, number one, to use the data, you better be registered. And then number two, can we measure the use of the PMP? And the answer is yes, we can measure it. We can't measure it perfectly down to each and every prescription. And does that prescription do the exemptions affect if the exemptions to checking the PMP, does that affect if a prescriber needs to look at it or not? We really can't measure like that. And we'll talk about that a little bit throughout this meeting. But the first piece that we're going to talk about is I've done analytics behind the scenes, and I'm trying to find a net size that captures the most non-compliant of prescribers. And when I say non-compliant, I mean, number one, you're either not registered to use the PMP, or number two, you have a high volume of prescriptions that you're issuing and you're not checking the PMP at all. So after doing analytics around it and really honing in on taking the feedback I got from last year's meeting and trying to figure out how do we find a net size that we can all manage through. Because what my step would be is to identify the most non-compliant and then pass those names on to the appropriate licensing board. And that's the plan I have here. And that's outlined on page 22. And what we said is, if we look over a 90-day period, we're looking at any prescriber that averaged 100 prescriptions a month for an opioid or benzodiazepine. So if you take all the opioids and benzodiazepines and average and add those up, and if the average was 100 of those a month, and they had 0 lookups, 0 queries of the PMP, we're going to alert the appropriate licensing board. And this stems from the fact that my statute says that if I see anything that looks like non-professional conduct, I must let the appropriate licensing board know. So, it's really hard to define that. And that's why I'm asking you guys for your input. But I came up with a net that is going to capture a reasonable amount. Right now, that net is capturing maybe about 120 prescribers right now. So it's not a burden on any one entity, because I'm cognizant of that. I know the Board of Pharmacy is busy, is very busy, and every one of these licensing boards here are really busy. So I don't want to capture 5,000 names, because none of us can work through that. So
What is the exact language in the regulation for when the CSPMP is supposed to be checked?
Could you repeat your question?
What is the exact language in the regulation for how often the CSPMP is to be checked?
Let me get the exact language. It really comes down to, this is Doug's words, so I'll start there. Doug's words is that for an opioid or a benzodiazepine for a healthcare practitioner, for a prescriber, they must check at the onset of treatment and every 90 days after, or every 3 months. And I guess the exact verbiage is new course of treatment, and that kind of leads into another piece of this discussion. But what is a new course of treatment? So what I tried to do is instead of trying to go after line by line, if a prescriber had to truly look at the PMP on any given one prescription, which is next to impossible right now, I just said, if you had 100 scripts in a month and 0 queries of the PMP, and I think that we would all say that the odds would be that one of those 100 you had to look up.
Have you run any reports already?
I have, yeah.
When you run it at 100, how many people? How many
That was the 120 that the net was capturing.
Okay, so if you ratcheted it down a little bit, like looked at what it would be for 90 or 80 or 70, I'm thinking 50.
I have, yeah. Like, so I took 100 and I took 50. And at 50, that net was going to capture more like around 400 at the time that I ran that report, Pat. So I thought, and then, and then the questions keep coming, like how many of those are nursing board versus PA versus the medical board versus osteo. So, I felt like we have to start somewhere. And the net that I came up with is it's a small net. It doesn't capture much.
Right. I mean, we have I know in our system, we have well over 20,000 providers. So you read a report that the results were 120 providers. And of course, they may not necessarily be Medicaid providers, but I don't think it's enough. I mean, we have a high mortality rate out there, and things are not getting better. This is where the pendulum is swinging, and people should be checking. And I think it's going to take some communication to let all the medical boards know that you will be checking and that you'll be notifying each board of their practitioners. But I think it's important to get all the boards involved to help, get people to check the CSPMP. But I think setting it at 100 and coming up with 120 providers out of well over 20,000 is a very, very minimal amount of providers.
I apologize too. I think I was Susie talking.
Yes.
All right. I'm sorry. I misidentified voices, but Susie, thanks for your feedback. And really this is open now. So I'd like to hear everybody. I did the best I could to come to the table and say, how do I make this manageable? I can do whatever the task force asks.
Okay. Doug, this is Pat. I do have a question. So I'm looking at the criteria that you selected. So I see the first two are over 90 days, and if you've made 0 queries in the CSPMP, which is similar to what we do for medical marijuana. We look to see, the Department of Health Services lets us know if somebody has not checked the CSPMP. So I get that. So if you meet those 2 criteria, then you guys are going to look at the other 4 pieces of information below that before you report to us, or?
Yeah, last year when we were talking, Pat, you had brought up that, just that one piece of information may or may not really would be impactful for the licensing board. But you did make the comment that, hey, maybe if you give us a more holistic view of not just looking at checking the PMP, but high prescribing habits, or and yes, we would only give those other 4 in this proposal here if you met qualification number 1, which you had an average of 100 scripts for opioid or benzos and 0 queries of the PMP.
Yeah, well, certainly the 0 queries. I mean, that is kind of, you need to be checking. If somebody has 0 queries, that is, I would have to agree, that is the ultimate red flag.
And to Susie's point, we can make that net bigger, smaller. I tried to take everybody's jobs into consideration and throw out a starting spot.
Well, I don't want, I certainly see the value of doing this, particularly where we are now. I guess I'm just concerned about how many of cases will we identify when we put this criteria in place. So,
like I said, right now, just looking at usage of the PMP, when I ran these reports 2 months ago, we were sitting at around 100, 120 using this criteria.
Right.
The criteria would become larger if we lower the thresholds. And
So I look at this kind of like we looked at the initial prescriber scorecards when they came out, when we looked at the number of prescribers that were writing for large quantities outside of their some of the lower the physicians that didn't have specialties, those kinds of things. So maybe we start with something like 100 and give the boards the opportunity to at least take a look at it, and then perhaps we revisit it in 6 months or something like that and see what the workload looks like, see what percentage of those actually turns out to be an issue for the boards. I'm certainly supportive of it. I think that, you know, everyone from the pharmacist to the practitioner has the responsibility to do this, to really make a difference for it. So I'm supportive in concept of at least starting someplace. I agree with Susie, that's probably too many, but I also think that the boards need to get a feel for what that individual workload might look like. So maybe, I don't know, I don't think 100 and something prescribe practitioners out of, you know, 30, what did you say, Doug, 35,000? I don't think that would probably be a huge issue for all of the boards when you look at it correspondingly, but everybody obviously has their own workload to look at.
I mean, I would welcome if we could start here and then revisit it, so we could just kind of get adjusted to see what, if any, staff changes we need to make or process change.
If I can jump in, I would agree that I think we need a starting point, and this seems like a good one that Doug's put some time and energy into. And I think going forward, if some of it's simply education, then we should see the numbers start coming down if we're getting out and talking to practitioners who are licensees of ours. If they're not using the CSPMP and they simply just need to be re-educated to do it, then they'll drop off the list, and hopefully our numbers would get smaller on who we have to go out and check on. But I think it also gives us and law enforcement an opportunity to see some of our victim doctors, because a lot of what we chase in DEA right now is fraud scripts, and a lot of the doctors are unaware of it, and it may show us more of them because they wouldn't be checking the PMP because they don't know that their registration's being used. So it would give us an opportunity to identify some of these doctors who are victims that don't know, because now we're calling them because we're getting notified about them not using the PMP.
Doug, this is something I feel like would perhaps be something that we would want to take to the Board of Pharmacy, since this would impact your staff and all those kinds of things. Is this something that we might want to motion on from this group, just for a consensus standpoint, so that we can say that a motion was taken on this particular item? Not to cut off the discussion, but it seems like the majority of the group feels like this is a good idea.
Yeah, I think that would be great. I think, you know, the two pieces would be, number one, do we all see value in that? And then if that answer is yes, then do we feel like this is a good starting spot? And, you know, I know that Susie brought up that, you know, we could maybe even be more restrictive, and maybe many of you feel the same way. I guess that's really the two questions, because I think our own board would want to hear what the task force had to say about the thresholds that we're establishing here. So thank you, Lori. So does anybody object to us doing this?
This is Debbie. I don't object at all. I mean, I think that this is a good idea. I guess one of my questions is, I know in the DHS regulations, there are some exceptions for checking the PDMP for certain types of conditions. I'm trying to remember if those same exceptions got put into statute.
Debbie, yes, there's I think they refer to them as exemptions, and the exemptions include things like hospice care and cancer treatments, and there's a laundry list of exemptions. And that's exactly why I say I can't really drill down to a certain prescription, say, should the pharmacist or should the prescriber or have looked at that particular for that prescription or not. I can't really do that because I don't know if there's an exemption in place. What I do know is the odds are that if you had 100 scripts in the month and you had 0 lookups, the odds are that one of those 100 you probably needed to look up.
Yeah.
Does that make sense?
I don't really have a good sense for the thresholds. I just, I think it's something for the boards to look at when they get these cases forwarded to them, that if it is an oncologist or if it is a hospice provider, that they are taking that into account.
I think that's a great point, Debbie. All I'm doing is giving information that no one has but me, And it's up to the other licensing board on, they have investigators. And again, I'm trying to be reasonable with their time, and not make this net so big that we're capturing, if we look at how many prescribers had 20 scripts and 0 lookups, it's over 10,000. 10,000. So
Doug,
nobody could work through that.
Doug, I think this is a reasonable starting point. And I also would like for us to coordinate keeping some data on what our results are on this, so that when we do revisit this and when we do meet again, that we'll have some type of data to look at to see, what the success of this was.
I think that's a great point. Great point.
But I'm definitely in support of taking some steps to do something here.
And then the second piece would be, do we want to keep the numbers I started with, or do we want to move it one direction or another?
Well, I as from the medical board's point of view, until we get a handle on what this is going to look like, I would request that we stay at this number and see where this leads. But that we regroup to maybe to specifically look at this in a given period of time.
And perhaps not wait all the way till a year from now. Maybe we look at meeting, say, in 6 months or something like that to establish how it's going and if that number could move from there. So any concerns with the 100?
Very good. Thank you guys so much. That gives me direction, and with that direction, I'll be myself or my staff will communicate any practitioners to meet those qualifications with you. If you have somebody that you want on your team to receive that, maybe an investigator versus you receiving those emails directly, just email me and let me know who you want that contact to be for whenever we start that. My next step is exactly like Ms. Walmsley said, is we're going to say that the task force has supported this. We're going to take it in front of our own board, make sure that our board members think that that's a good thing. And then we'll start getting busy, and then I'll communicate with you guys.
Doug, if I may, will you give us some notice after your board meets and when you're going to start implementing it, just so we can be aware of that this is coming, it's been approved, and we're going to start doing this.
Absolutely, good idea. I sure will.
Thank you.
You're welcome. Okay, so I think we can move on to the part about measuring compliance with data reporting into the PMP. So again, that becomes more of a pharmacy role. For the most part, almost all dispensations of controlled substances are coming from pharmacies. So our law says that you must report into the CSPMP daily. And what is a little bit tricky is ASAP standards that I referred to earlier. There are fields in ASAP standards that are, one is the field date and one is a sold date. And those are, by that upgrade to 4.2b, we can capture both a field date and a sold date. And I think almost all healthcare practitioners will tell you that they want to know the sold date more than the filled date. Pharmacy may fill it, it may be sitting on their shelf for a couple of days, and it might be sitting there because the doctor even wrote, or nurse practitioner or PA, they may have written that do not fill until such and such date on the script. And I get phone calls like this all the time where the prescriber is really frustrated because the pharmacy, it shows that the pharmacy filled it on a date that was earlier than what they suggested on the script. Well, the pharmacy may have actually wrote a note to, and maybe Lori would speak to this too, but the pharmacy may they may package the drug up, but have a note in the will call section that says, do not release to the patient until such and such date. And so no one knows what date the patient really received it versus what day it was filled. I think that to really measure compliance for the data submitters, we need the fill date and sold date reported to the PMP. And with that sold date, we can know when a data submitter should have submitted the data into the PMP, so we can measure compliance better. So, Ms. Walmsley, do you have any comments on what I'm talking about? That, and does that make sense?
Yeah, I 100% agree with that, Doug. You know, there's a lot of times from a pharmacy workflow standpoint that a prescription might come in through an electronic prescription, and the pharmacy might go ahead and do some of the steps to get the prescription ready, but plan to hold the prescription, as you mentioned, until it's time for the prescription to actually be dispensed to the patient. And there is some confusion around what the date dispense means. Does that mean it's the date that the pharmacist checks it for accuracy, or is that the date that the patient actually physically has access to the drug? I think most pharmacies look at it as the date that the patient actually receives the drug, because obviously they can't take it until they have it. But I think that having access to both of those dates would really help to provide a lot more clarity for the practitioners that are looking at it to ensure when patients actually physically receive the product to go home with. So I'm in support of it.
You know, and on the same note as going after the most non-compliant prescribers looking at the PMP, I'm taking the same approach with data submitters. You know, I'm not drilling down day to day and saying you missed one day. I'm looking at trends. I'm looking at, has this pharmacy not reported in 10 days? Then we got some issues. So we're going after the most non-compliant here also. But I think that we want our pharmacies to know when they're supposed to be reporting, and some pharmacies, like Ms. Walmsley said, some pharmacies report off fill date, some sold date. What's right? I think sold date. That to me is when it leaves with the patient. That is a part of the definition of dispensed right now. But the other piece of the definition, dispense, talks about the packaging, labeling, compounding, and that makes room for second guessing. Should you be reporting on the fill date or the sold date? So why not capture both? Any concerns with us if we ever ran any type of legislation asking for that type of information to be reported from the PMP, reported from the pharmacy into the PMP? Does anybody have any concerns there? Awesome. I kind of combined a little bit of 6 and 7 there together, so I'm sorry. Agenda item 7. I talk about the first one is take home naloxone provided in emergency rooms. So again, we're talking about what legislation changes would the Board of Pharmacy get involved with potentially next year. And you know, when we look at what happened this past year, was there was a bill that it was Senate Bill 1087 that was passed that caused some changes to ARS 362608, and 2608 is about the reporting into the PMP. And what it's stating now is that we always wanted naloxone to be reported from the pharmacies. And that's been in effect since 2017. And I believe at that point, that's when the governor had issued the opioid epidemic within Arizona. So in 2017, we said pharmacies should be reporting naloxone in. We want that. We think that's valuable information. That's information I give to Jackie and her team at ADHS every week. And Jackie's team puts that up on a dashboard. So it's really good data. But the way this was written into 362608, it appears that practitioners working in the ER also would have to report into the PMP any dispensation of naloxone. That wasn't the intent here. If any of you don't know, a lot of hospitals are, if somebody has an OD, if there's an OD in the hospital, a lot of the ERs are giving naloxone directly to the patient from the ER to go home with. And they're doing it because they know the patient won't go to the pharmacy and go get it. So they have this supply of naloxone. They're handing it to those that had an overdose. And I think we would all say that's a good thing. We know naloxone saves lives. So send them home with the naloxone, but we don't want them to have to report that. That wasn't the intent here. So I think and Dr. Gandhi, you tell me if I'm misspeaking, but I think the Board of Pharmacy would say that we want to clean that up because we support that.
That is correct, Doug. I think you captured it perfectly, and we will fix that next legislative session.
Sounds good. Jackie, do you have anything you want to add to that?
That just made me really happy to hear that, because that was on my legislative list for changes to be pushed at ADHS. So yes, my office, myself, I've been working with the emergency department physicians, trying to provide naloxone to patients that are at high risk of future overdose when they're discharged from the EDs. So we are providing a couple of things that probably should be noted are that ADHS is providing the hospitals with pre-packaged Narcan nasal kits, and the hospitals are not paying for the Narcan. ADHS is providing it so that they can pass it along to the patients at no cost to the patients. And yes, there are studies that patients do not fill prescriptions when they leave the hospital for Narcan. So additionally, we've collected data throughout the year in reviewing fatal drug overdoses. And our data shows that within 30 days of a fatal overdose, 1 out of 2 people have had a healthcare provider contact, meaning that they were either in the hospital or had been to a medical facility. So we know it's a really important, critical point of intervention because, most of these people, the records we look at have been in the hospitals prior to death. So we would really like to see that, and having to have the ED docs report the Narcan being given to these patients presents yet another barrier. So we appreciate you working with us very much.
No problem. I like I said earlier, I don't think it was our intent at all, but it's just where that got placed in the statute. It reads that way. So we'll work with you and we'll get that corrected. Okay.
Great. Thank you so much.
Real good.
Doug, thanks for picking that up. We would support the change as well.
Thank you, Debbie. So if I can move to 7B, this is another great topic with ADHS. And for years, ADHS and I have, we have these discussions about the overdose fatality review teams. And what's interesting is when you read who has access to the PMP, it says, you know, prescribers and pharmacists, but it also says when they're treating a patient. And when you have a fatal overdose, nobody's treating the patient anymore. So finding people that have the ability to access PMP records for the sake of doing good overdose fatality review work. There isn't many people that can pull the reports based on the way the statute reads right now. And these are the people within our state right now and Jackie, I'm gonna let you speak to this because you can speak to it better than I can, but you know, historically it was a group doing it more at a state level through Department of Health efforts, but most recently our goal is to have these overdose fatality review teams in every county, right? And as you have more and more people doing that kind of work, how do they get the right access to the PMP so that they can do the work that they're trying to do? And maybe if it's okay, Jackie, I'll put you on the spot, and I'm not sure if I'm verbalizing it the best, but I'll let you take over.
Yeah, that's right. So under ARS 198, ADHS is required to establish not only a state drug overdose fatality review team, but also to support and establish local jurisdiction or local county overdose fatality review teams. So we fund the local county health departments, not all of them, but a large number of them now, and to help them establish their own local overdose fatality review teams. And the goal with that, excuse me, is collaboration within their community. So this requires collaboration amongst medical providers, medical examiners, law enforcement, behavioral health professionals, and so on. So, and also with local overdose fatality review teams, they're familiar with the uniqueness of their community and what resources they may or may not have. So with that, as part of the drug overdose review process, we request records from a variety of law enforcement, DCS, medical, and so on. And the CSPMP has always been an important part of the review process in that we're looking to see if the decedent had been prescribed controlled substances prior to their death. Now, what Dr. Borowski had mentioned earlier really rings true. I think, you know, we look back not within 3 years, but really it would probably make sense to do even a further look back. But so at the state level, we have statutory authority under 36-19801 to request any records that are necessary to perform a review of the fatal overdose. And so the local jurisdictions, they also are wanting access to the prescription history for the decedents that they're reviewing in their local county teams. And so that's where, you know, ADHS has statutory authority. We can get access to records, but it's not our data to share with the local counties. So we need to figure out, do we need to amend that language to add the local, you know, OFR teams? I don't know, but that's where we're at right now, trying to get the information so that the local teams can get access to the CSPMP as well. And the medical examiners, not all counties, and the problem is local teams, not all counties are created equal, as most of us know on this call. And so not everybody has an ME office. So with the MEs, they can certainly access the CSPMP, but not all counties have an ME or a core, you know, they have coroners, And they don't even have, the ability to carry out a lot of the autopsies or the testing because of budgets restrictions in some of the really rural areas. So that is a dilemma.
So I know that you have mine, and I'll let Cam answer for himself, but I think between the three of us working together, we should be able to find a way to give the people that are doing this meaningful work access to the PMP. I guess from the standpoint of the task force, does anybody have any concerns about that? Okay. Well, we'll pass that on to our own licensing board, okay?
Okay, sounds good. Thank you so much.
You're so welcome. Possible other legislative changes, and I want to make it clear, I'm not advocating for this. I am throwing it out there to let everybody think about the future, and when I think about the future, we may one day be able to understand if a certain prescription should have been looked at. And it might be for the sake of, reporting to other licensing boards. It might be for lawsuits. It could be for a lot of different reasons. And when I think about measuring compliance in the future, a couple things would need to be either defined or changed to ever drill down to that level. And again, I'm just bringing it up as food for thought. I'm not suggesting we have to get to the bottom of it today. But what we talked about this a little bit ago, where you have to check the PMP upon a new course of treatment. And there is no definition of a new course of treatment. So I think we all may have a little different if I had to write down what a new course of treatment was, it might be different versus others here. So, and just talking out loud, if you change from a 10 milligram dose to a 20 milligram dose, is that a new course of treatment? If you go from BID to TIT, is that a new course of treatment? If you go from one drug to another drug in the same class, is that a new course of treatment? So it's a little bit tough to measure compliance down to that level. And obviously that's not our goal today, right? Our goal today was to get started, make a small net and see how we can together work through that. But over due time, we may need some type of definition for a new course of treatment. Any comments, guys? I looked as much as I could through all of your guys' statutes from the other licensing boards as well as other states, and I put a few examples of what other states have in their language. I'm not sure that I like it more or less. I just wanted you to be able to visually see some of the differences. Is there anything that anybody would want to do at this point in time? Okay. Agenda item 8 is ICD-10 codes. Kind of goes hand in hand with everything we just were talking about. That is, if you ever wanted to know more about the exemptions to checking the PMP, the only way you would know them is if ICD-10 codes were reported to the PMP. And again, I'm not being the advocate of it. I'm just stating that if you ever were looking me in the eye and saying, Doug, when will you ever get there? My answer would be whenever ICD-10 codes are reported to the PMP. You know, the ICD-10 code would clue in that it was a hospice patient or a cancer patient. And then I would be able to say, well, the prescriber or pharmacist did not need to look at the PMP in this particular case because of this situation. So the last I knew, Nevada requires ICD-10 codes. I don't know if there's other states at all that do, just in case you guys are wondering that. You know, of course, if we ever got to that point, we would have to require it on the script so that the pharmacist would have it to be able to enter it into the PMP. And I think there's a lot of people that would want to weigh in on that whole conversation. So again, I'm not saying that's what we should do. I am just making it clear that if I ever needed to drill down to that level, I would need ICD-10 codes reported to the PMP, or I would need the exemptions to be eliminated. If there were no exemptions, we would be able to measure compliance down to a prescription level. Any comments there?
Hi, this is Susie Berman again. So, you know, we have several exemptions in policy that don't necessarily line up with what is in the legislation, and we had put ours into policy prior to legislation. But we also have a document that directs the pharmacy on how to override for an exemption. So one of our exemptions is patients with traumatic injury. So Dr. Salik did go through, and there's about 2,000 codes that qualify under that. And so in some of the exemptions, it does require an ICD-10 code. You know, and that's to get the exemption. That's a way different. That's different than requiring ICD-10s on everything, and that can become a big access to care treatment issue. So I'm not saying not to use them, but use them where you think they're going to really be useful and maybe make a difference. But to use them on all prescriptions, all controlled substances prescriptions, it's good. It'll be an access to care issue.
Thank you so much for that, Susie.
I tend to agree with that as well. I think we're taking some steps after this meeting already to look to identify some of the low-hanging fruit with non-compliance, both on the pharmacy side and on the prescribing practitioner side. So I would be in favor of, let's see what modifications we can make over the next year, and perhaps discuss this in the next meeting, some of these other additional topics around additional things, rather than looking at another mandate.
Thank you guys so much for that feedback. Any other comments on ICD-10 codes? If not, I'm going to skip 9 because I think I threw 10 in on the last minute, and Lynn helped me out there. But you know, we cover a lot of information during these calls, and I try to be respectful of everyone's time. And now we're talking about measuring compliance and feedback on that, and where do we go as we move forward. And it made me think that do we need this meeting a little more often than once a year? And you know, I guess I'm I'm thinking, like everything, if we want to move it to twice a year, at least we're not going too far. I know I don't have the bandwidth to do monthly meetings, but if you feel like it's going to add value and allow for meaningful dialogue, I sure have no problem moving this into twice a year or quarterly if that's what we need to do. But I just wanted your guys' opinions on that.
This is Melissa. I think it would be valuable. I mean, I gather a lot from this meeting, and when it comes to, at least the areas that we're involved in, I think a twice a year touch base would be helpful. But I would defer to others on the task force who have different scopes of being involved in this.
Hi, Doug. It's Julie from DEA. I concur. I think meeting more than once a year would be beneficial for this task force.
This is Pat McSorley. I do agree with that too. I think we're starting to move into a position where there's lots of things we want to look at. So I do think meeting twice a year would be good.
Anybody object to twice a year meeting? And then if we feel like we need more than that moving forward, we'll talk about it during the next meeting.
So maybe, Doug, you should just ask everybody to raise their hand if they're in favor. There's a little reaction button. Get a quick count.
I can do that. So would you raise your hand if you're in support of twice a year meeting?
I'm in support. I just can't find the hand.
No worries.
Dr. Borowski, you're going old school.
Well, good. We will do that, and I'll put some communication out, as we figure out when the next one will be. Ms. Walmsley told me that I may have missed item 7C, which is the daily reporting requirement. And I think that's where I think I was in item 6 and I kind of overlapped it into 7, where I was talking about possibly capturing the fill date and the sold date. So in case there was any confusion there, item 7, 7C was about that, capture and fill date, sold date.
Thank you, Doug.
Okay, sounds good. Well, we're following open meeting law, and we always allow for a call to the public. Because the public sees this as a delay on their end, we're going to hang in there about 2 minutes. And right now we're making the call to the public. We'll see if there's anybody that would like to say anything. And if any of you have something you'd like to say, you're welcome too. And maybe even like, items that you want to talk about during our next task force meeting. And of course, I'm always available to email for the task force members, but feel free to share anything you have on your mind. I just heard from Lynn, and he told me that we have no comments from the public. So unless I hear anything from any of you, this meeting's adjourned, and I'll turn it over to Miss Walmsley. She'll do it a little bit better than I will. But we will definitely have another meeting in the next half year, and I think that's an important thing for all of us. So. Ms. Walmsley, it's all yours.
Thank you, Doug. Thank you for the very informative updates around the CSPMP. I think it was a really great meeting. I really appreciate everybody's attendance today and your open collaboration. I feel like we got some good next steps to take forward to the Board of Pharmacy. So appreciate everybody's participation and your desire to go ahead and serve and get back together a little bit more frequently. We'll go ahead and adjourn the meeting and look forward to meeting with you all again in about 6 months. So thank you.
Thank you.